Welcome to Season 1, Episode 2 of Behind the Research with the Journal of the American Osteopathic Association. I'm Melissa Schmidt, Director of the JAOA, and in this podcast, it's my pleasure and privilege to meet with authors of papers recently published in the journal to discuss not just their findings, but their methodology, their research process, their expectations, and maybe even some surprises as they conducted their studies, as well as their plans to build on their results. My guests today are Dr. Danielle Prentice and Dr. Amanda Berry, two of the 6 authors on a paper from our October issue entitled Opioid Use in the Postpartum Period, Are We Prescribing Too Much?, which you can read now online at jaoa.org. In this pilot study, the authors reviewed the medical records of 37 patients who delivered either vaginally or via cesarean section at a community hospital in Oklahoma, analyzing the number of opioid pills they were prescribed. The authors then followed up with a survey 4 to 6 weeks after discharge to track the number of pills that had gone unused by these patients and found an overall average of 9.1 pills left at the end of that period. Today, I'll be talking with them about the motivation for their study and the implications of these results in the context of the opioid epidemic. So welcome, Dr. Prentice and Dr. Berry, and thanks so much for joining me. I'm hoping both of you will just take a moment, and we'll start with you, Dr. Prentice, and then Dr. Berry. Introduce yourselves, please, and tell me a little bit about your background.
Okay. Hi, I'm Danielle Prentice. I am currently a second-year maternal fetal medicine fellow at Penn State. I grew up in New Jersey, went to college in Colorado, then went to medical school at Oklahoma State College of Osteopathic Medicine, and then did my residency at St. Anthony's in Oklahoma City.
Great. And Dr. Berry?
So I'm Amanda Berry. I am a 4th-year OB resident at St. Anthony in Oklahoma City. I originally grew up in Cypress, which is outside of Houston, Texas. I went to undergrad at Millsaps College in Jackson, Mississippi. I got my master's degree from Mississippi College just outside of Jackson, and then I went to medical school in Mississippi as well in Hattiesburg at William Carey, and then I ended up in Oklahoma. I've been here
Great.
since.
So what connected you two to each other, and all 6 of the authors to each other? Have you previously worked together, and is this the first research project you've undertaken together?
Yes, so Amanda and I were co-residents. So that's kind of how we became connected at that, based on how our residency was set up and how our research infrastructure was set up. It was much easier to conduct research at one of the hospitals we cover instead of the other one. And so part of that is it's mostly our second-year residents that cover over at that hospital. So it became really important to have a partner who was available and able to discuss the project with patients, consent patients, someone who understood the reasoning behind the research and had a passion for that kind of research so that the patients would hopefully want to participate with us and let us call them and ask them questions about their opioid use postpartum. So that is sort of how I recruited Amanda to help with the project.
Great. So you sort of mentioned having kind of a simpatico line of thinking about the importance of this research. So what inspired you to do the research and what led to it? Was there a particular previous publication that you were building on? I assume maybe you saw something in your clinical work during residency, or was it just a larger sense of kind of the opioid dependency that we're noticing?
Right. So I think with research, particularly in residency, and particularly when you're at a community-based program, it's important to pick something that you are seeing in your clinical practice. Obviously, is more difficult to do basic science research and such at a community hospital, but you always have access to patients.
Yeah.
So in Oklahoma City, and in Oklahoma in particular, we had a large population of women who have opioid dependence and were on maintenance therapy for opioid dependence. And so it was obvious to us that this was not only an issue that was a hot topic in the country, but that particularly affected our patients that we were seeing. And so that was a component of it. The other thing is, just as a practicing resident, you are the person who is prescribing the medications for the patients when they're going home. And we were able to see that different attendings had different practices, and that the institutions we were at didn't have a specific protocol for prescribing opioids. And so when we noticed that issue and difference in practice, it made me question what we were doing and why we were doing it, and then look into the literature that already existed surrounding that topic, particularly on the risk of continued use after the postpartum period.
That's really kind of a perfect triad of research motivation, that inconsistency that you noticed, patterns that you noticed in your own patients, curiosity on your part, and of course being a topic of kind of community importance. So I can see why that would have inspired you and made the project interesting and exciting to take on. As you kind of suggested in some of your comments, this is obviously a really large and kind of multifaceted issue. This might be just sort of a natural conclusion with how your study was structured, but how did you focus on survey-based methodology to assess that number of unused pills? Was that the easiest way to follow up with your patients?
Yes. I think it would have been really difficult. Obviously, a better way to be able to do it without having bias introduced just from patient reporting would be to have them bring their pills back afterwards and see how many they took and how many were left. But the logistics of that would be probably a nightmare, and getting IRB approval to even collect opioids, and then what do you do with those opioids would be a really interesting thing to do. Right. And since this was a pilot study, we kind of just wanted to get an idea of what these patients were taking, how much they were taking, just so that we could better prescribe in the future. So that the survey-based method for the type of research infrastructure that was available to us was the best way for us to go.
That makes sense. And that is sort of why I was asking the question, because I know listeners who are either other authors at the JAOA are sort of younger in their medical student career and are looking to conduct research, or just AOA members overall often, I think, don't understand that natural introduction of bias when you ask a patient for kind of subjective reporting, especially in this kind of scenario where there might be some embarrassment to report a certain number either taken or left.
Right.
So, I think it was kind of important to discuss that bias, but in this particular scenario, that was, the perfect way to go about assessing it in this kind of pilot methodology. What was your research process like? So Dr. Prentice, you sort of started off saying it was easier at one of the hospitals where you both rotate. You certainly needed people who were equally committed to the work, equally available, had a certain ethos in the way they dealt with patients, where they could be trusted. So how did the two of you and then all six of you as a group kind of divide the work, and how long did it take you from idea to submission?
I'm trying to think of how long it even took, but really it just started with an idea, I guess, in my second or third year?
Yes, the idea started when I remember, because we were working together. So our program, we're really lucky when we're interns, we're always with an upper level when we work, and Danielle and I happened to be working on call shifts together, and we just were kind of brainstorming ideas back and forth of what she wanted to do to complete for her research project, and this idea came up, and that was kind of how, as she transitioned into fourth year in the spring into the summer, and then I transitioned into second year, how we kind of worked together, and I was eventually at the facility she's talking about to help with the consenting process, and kind of that was where that part started as far as the idea.
Yes, and so we covered 2 labor and deliveries in our residency program, and at our main hospital at the time when I was trying to get this project going, we did not have an IRB set up at the hospital.
Mm.
And so obviously that makes it really difficult to do any patient-based research where you need to consent patients and have IRB approval. And you can always go into a private IRB. There's a lot of them online. They just cost a lot of money.
Yeah.
They cost about $3,000 for project review. And that was something obviously we would have liked to avoid because we were residents not making a whole lot of money and not with a lot of research funding. So the other hospital we worked at did have an IRB in place. And so we were able to utilize their program. There was a lot of help for that as well through their program coordinator. And so the IRB approval itself, particularly for a project like that, we weren't doing anything to people or
right. It wasn't
we were just asking
interventional.
questions.
Yeah.
It wasn't interventional. So the approval process was not bad. It actually got approved pretty quickly. And so once we got past that, the start was really just to talk to patients and get patients going. So we both consented patients. I would say Amanda did most of the consenting work. I did that when I covered over there randomly, but she was there for large chunks of time. And we consented a lot more patients than actually ended up being in the study at the end,
Right.
just because of difficulty reaching them over the phone for survey. A lot of patients' numbers were unable to be reached. We left lots of messages. We did a lot of that kind of stuff. And so our response rate was pretty low compared to the amount of people that we consented to do this project. But I think that is incredibly common in research, particularly in survey-based projects.
Yeah, 100%.
Yeah. And then the other authors were really pretty instrumental in the writing process, in some of the statistical analysis, and then just supporting us in general with the research.
Great. So I want to talk about your results, obviously, but before we get to that, I want to talk about some of the opening lines of your paper. And if you all don't mind, I'm going to read directs from the paper. So for example, a 5-day supply is linked to a 10% chance of continued use at 1 year and a 5% chance of continued use at 3 years. The risk of persistent opioid use after the postpartum period is associated with a single prescription, regardless of drug delivery route. And further, that 1 in 300 women who were prescribed opioids after a cesarean section became dependent. I suspect that some of those statistics might surprise even your DO colleagues, and they absolutely would surprise patients. So I guess my questions to both of you are, do you think that's common knowledge? And then do you happen to know how those rates compare to new persistent opioid use rates after other surgeries? So I'm wondering if new mothers, kind of because of the swirl of things around that time, are more susceptible to that, or if that is just kind of a common post-surgical occurrence.
So I would say that it's probably not common knowledge, but it's becoming more common. Obviously, the opioid epidemic per se has become a hot topic issue.
Sure.
It cycles through the news all the time, and prescribing practices have really been called into the forefront of reasons behind people developing dependence for opioids. Even recently, I actually pulled a paper that was published. It's in the most recent. It's been published really recently. It's actually this month. And they were talking about exactly that. So new persistent opioid use after acute opioid prescribing in pregnancy. And so they looked at it not only just in the postpartum period, but anytime somebody was given an opioid prescription in pregnancy. And their results were also really, really interesting. And they looked into they saw that regardless of route of delivery, for cesarean delivery or for vaginal delivery, there was about a 6% chance of continued use. Oh no, sorry, hold on 1 second. So 6% of all pregnant women were given at least one opioid prescription during pregnancy. And then there's factors associated with filling that. And then they looked at persistent use, the factors associated with persistent use after that, and then having a procedure in pregnancy. And they just concluded really that opioid prescription during pregnancy, they're more likely to experience new persistent opioid use. And they do discuss in the paper more so than just if someone went and had knee surgery, although we know if someone had knee surgery or any other kind of surgery, there is that risk. But the risk in the postpartum period and in pregnancy tends to seem, at least by the literature, to be a little bit higher than what we see in other surgical procedures. And what's really exciting is that people are focusing on this now, and you're seeing more and more research coming out about this. And so I think that's really important.
I think that's so important because there are so many ways that new mothers kind of slip through the cracks of the healthcare system in different arenas, but particularly if the risk is equivalent to or even higher in the postpartum period of this particular type of dependency. I think your research and obviously some subsequent research as well. And I'll post the link to that article.
Yes, please. That's what I was going to ask.
Comments for the podcast, sure, so that readers can see that as well. But obviously, this is an area of necessary and continuing research. So while your study was observational, as we talked about, not interventional, and you had a relatively small sample size, which you noted, the mean number of unused pills across the study population was 9.1. So there's definitely a clear conclusion that, at least in the case of your patients, overprescribing was an issue. Were you expecting such a high number of unused pills? Did that sort of meet whatever hypothesis you went in with, or did you not have any idea how many would be left at the end?
My general thought was at the time that we were overprescribing, especially based on other practices that I had seen and other articles that I had read. I don't think that I thought that it would be that much, and then to take that amount of pills and just generalize it to our population at a small community hospital and look at how much that added to the community in terms
just from a single
pills.
hospital. Yeah.
Just from a single hospital and not a very big one at that. So that was something that the overall numbers at the end surprised me.
So in terms of prescribing guidelines, then one of the upshots and the conclusions of your article is that you definitely recommend implementation of standardized prescribing guidelines. So in the paper, you said it's evident that based on these numbers, standard guidelines for prescribing in the postpartum period should lower the number of opioid pills entering the community, as well as the potential for misuse and abuse. And then subsequently, the DO, which is the AOA's member newsletter and magazine, did an interview with you, Dr. Prentice, and you further clarified these findings do not minimize the pain women feel postpartum or dispute that physicians are best suited to prescribe appropriate pain medication, which I definitely think both of those things are important caveats. But rather they act as a call to action to rethink our standard prescribing practices, which are often out of line with a new mom's needs. So in the study, you noted for your readers that you concluded it early due to a change in Oklahoma's prescribing laws that went into effect November 1st, 2018, and had some potential to introduce bias and sort of confound the results that you were finding. I'm hoping you both can tell me a little bit about the legal changes at that time and where they stand today.
So the new prescribing laws that went into effect really limited the number of total opioids you could prescribe for acute pain at the time. So it changed laws that you could give no longer than a 7-day supply to a patient after or for an acute problem. Otherwise, they would have to return for an in-person visit with the physician in order to get a renewal on the prescription. It could, again, only be a 7-day supply. And if they required any more than a third supply, then they had to be referred to pain management at that point in order to limit the number of opioids they were prescribed for a short-term problem. So if after 3 weeks they're still having issues, that's when they're then referred for pain management. And then it also required that we had to consent patients on the risks that come with opioids, specifically when mixing them with certain medications that can be depressants as well. And we have to let them know that there's risks of dependency and even overdose and abuse that are associated with the opioids. So people have to actually consent and agree verbally to these things. And then depending on if they take medications that were deemed by the state to be problematic possibly, then they have to also sign paperwork stating that they understand the risk they're taking, that there's quite a few things that they know they can be drug tested at any time. They have to bring their pills to clinic with them and have them counted if needed. And there's a lot more that goes into it now than just giving a prescription. And so it's a lot more detailed on our end and making sure our patients are aware of the risk that comes with them so that they're okay when they take them.
Sure. Do you know what brought that about? So what kind of advocacy was required? Who led that charge? What sort of lessons are there for other states and even on an individual level, your DO colleagues advocating at the state level?
I'm honestly not sure how it came about. I mean, it started just as I was starting my second year, so I hadn't really been part of the process in Oklahoma beforehand. I'm not sure if Danielle knows anymore.
I don't know who in particular was behind that. I know that prior to that, earlier in like the 2010s, Oklahoma was top in the United States of prescriptions per person in the United States. And it was a problem. I think that there were about 107 prescriptions for about every 100 people. So there's more prescriptions than people in Oklahoma. So it was a problem. Even so, with the passage of this law, it's still, I don't know how to say this exactly, but it was controversial because there is a fine line between advocating for proper prescribing and also limiting the ability to properly treat someone's pain.
Sure.
And so it's definitely not a perfect model. I'm not sure exactly the work group that was put together in order to come up with this process. But I hope with other states doing this in the future that they really look into the research and the medical literature and also involve physicians, which I don't know if they did in this, but involve a larger group of physicians to come up with a process that is both good for the patients and for prescribers.
I think that can be a really thin line to walk, a fine needle to thread. And you all addressed it very delicately in the JAOA article in terms of your research by just saying it could have sort of introduced some bias or confound the results. But I'm glad we got a chance to talk about that in more depth here, because I can see that concern on the part of any medical professional that you, as you said, does it limit your ability to really acknowledge and treat your patient's pain? So I think, as you said, having physicians involved in those legal decisions is really crucial. Did any of your other results surprise you? Anything you'd like to highlight here?
I don't think anything else surprised me. I would say that I anticipated that the vast majority of our patients would not dispose of their pills and would keep them. So that was something that I included in there mostly to prove a point. And that point is that when you overprescribe, those pills stay in the community. They aren't going anywhere else. So that wasn't necessarily a surprise, but something that I wanted to have in there. One of the things that surprised me, which probably is it's not related exactly to numbers and the results, were that patients were really open about keeping their pills and using them for other things like migraines and toothaches and all sorts of things. And so that made me laugh, actually, because although we couldn't quantify that, and this wasn't a qualitative study, but it would be a good area for a qualitative study, they were really open about keeping their pills and reusing them for other things.
Yeah, I would agree. I was a little worried about kind of the bias, but possibly going in the other direction even. I was a little concerned when we started calling patients. They'd say, oh, I used them all, or oh, there's none left, or they,
Mm-hmm.
had picked disposal. And all of them, in my opinion, when talking, were very honest with what they did, whether it would be something you would do personally or not, which wasn't part of it, but they just were very open. And I felt like that really helped in kind of learning and giving ideas for the like offshoots of how we can further research this and look into this and what we can do to help our patients.
I think that says a lot too, going back to you all talking about the consenting process, about the trust that you work to build with your patients, because I think particularly in any kind of study that relies on survey-based outcomes, and particularly, as you said, if you move on to a qualitative study in this regard, that relationship that you've built with patients is crucial to getting real data, real reporting. And in terms of disposal, that was going to be sort of my next question for you, because I thought that was an interesting portion of the article and something really worthwhile to highlight. So you note that Oklahoma actually has a strong disposal program, most likely as a result of some of what you were talking about in the 2010s, that those really high rates of prescription and usage sort of necessitate that strong disposal program. But you also note that similar programs are really underused, likely because patients aren't really aware of them, education is lacking, marketing is lacking. Do you have any recommendations that you want to share on that front about, you all built the relationship with patients. What would have been the way to reach them to let them know about proper disposal methods, provided they weren't keeping them for toothaches?
Right. I think just even bringing it up to begin with, when you prescribe opioids, if you could have something in their discharge paperwork about where they're able to dispose of these medications. And then also accessibility. We worked in a community hospital setting in a low-income area where a lot of people don't have cars. They take the buses to get to their appointments. They have difficulty getting to the hospital in general. And there isn't necessarily a great infrastructure to get patients from one place to another easily in order to dispose of this. And so if you can have disposal programs at places where people are going to need to naturally be, that would be what would be best. So if you could have one of our patients that did dispose of them at her pediatrician's office, they had a disposal program there, which they have, if you have a baby, you're going to have to go to your pediatrician's office. And so that would be one of the recommendations that I would give, is to have these locations where you can dispose of the pills be places where people naturally need to go and will need to find transportation to get there regardless of the situation.
It seems like definitely placement and availability. So putting those locations in the correct spots, but also, as you said, sort of connecting those dots that if new mothers are going to the pediatrician anyway, having a pediatrician ask those questions during those appointments. Do you have any that you want to dispose of? Whether it's the doctor or the PA or whoever, intakes the patient or helps them check out. Those reminders seem like they might be helpful, some sort of person-to-person contact in that regard. So what do you all see as the best path forward here, whether that's research-wise? I know you mentioned a qualitative study, or legislatively speaking. What would you advocate for to your DO colleagues around this topic?
Amanda, did you want to talk a little bit about disposal and having an education program for disposal?
Yeah, so I have been working on an IRB-approved study to discuss with patients at the time of their delivery that they're educated on where facilities are, specifically in our area, and they're given a handout that shows the name, address, phone number, and distance from the hospital of the different places that they can go. With a little bit of, I'm doing the same type of survey-based study, but with the few patients that I have so far, it's been about 50-50, which I feel like is at least a bigger improvement than what we had in previously. So people
Right.
are being educated on where to take them, and at least half of them are going there. Of the 50% that didn't take it, half of those used the entire prescription, so there wasn't anything to return. So I feel like as of right now, it's showing promise that hopefully educating patients and giving them kind of distinct places to go on their return would be really helpful. Most of our locations are CVS, Walgreens, and either fire departments or police stations.
Mm-hmm.
So it's kind of easy. There's I can't think of the website right now, but there was, at least for Oklahoma, there was a website you can go into and you can type your location and it'll show you all of the surrounding location area, drop-off location areas within a X mile radius that you input. So I thought that was really helpful, which is how I figured out where people could go. So I think that's kind of the next step, at least longitudinally with this, like educating, seeing how much they had left over, educating people that we know you have pain, we know that you need make sure that it doesn't either get outside of your house or your community or in the hands of your kids if you have babies at home.
That's great. That's really great. So let's talk a bit. First of all, I hope that study will come to us for submission. But let's talk a bit about taking the project to publication. So did you find writing up your results challenging? Was peer review and publication challenging in any special way? How about revision requests? What would you like to share with readers or fellow authors and researchers about that process?
Yeah, I think I would say that writing up the paper wasn't necessarily that difficult. I actually presented some of the results in Japan. And so I had a presentation put together that I had used there. And so I had done a lot of the research for things like the introduction and the background and all of that. And I had an abstract that I could change a little bit based on the rest of our data collected. So writing it up wasn't very difficult. I had a friend mentor do my statistics for me, and so I didn't have to wait a really long time to get my statistics done. If I wanted something rerun a little bit differently, that was really easy to get done as well. And
that's a good friend to have.
It is a really great friend and mentor
challenging.
and mentor to have, absolutely. And that's Heather Wilkins. She's on the paper. So that was really nice to have. As far as the entire submission process and peer review process, I think that really when we submitted, I felt like the peer review process was pretty fast to begin with. We got the recommendations for minor revision, resubmitted that. At times it can be difficult to sort of sparse out the reviewers' comments because sometimes they're a little contradictory, and then trying to figure out adding things without going over the word limit when you're already close to the word limit can be a little bit on the difficult side, but all things we were able to make work. I think the most difficult part, and I think that there have been some changes in this process that have occurred already, is that the entire process of peer review and revisions happened really fast. The paper was accepted pretty quickly, and then we waited a really long time for publication.
Yeah.
And I think, everyone was so kind about that. I'm not really sure what happened in the interim, but it seemed almost like the process in general has changed in the meantime.
I think that's true. And I'm glad that you brought that up, because although the podcast isn't for that purpose, it is a good opportunity for me to sort of share with you all as authors and with people who are listening how some of those changes have come about at the JAOA. So historically, it has taken, I would say, an inordinately long time from acceptance to publication, to the point that if you have time-sensitive data, by the time it appears in print, it may or may not still be valid. So that's something in the past 12 months that we have increasingly focused on, and tried to, at this point, if a paper is accepted today, we are within an average of 4 months from acceptance to online first publication, which is dramatically different than it was in the past. And that's one of the reasons that the JAOA has moved so fiercely and quickly toward more digital publication for exactly that reason. Because, you know, publications operate in a lot of different ways, and they're kind of bound by page counts. You can only put a certain number of articles in each issue, and we were not editing articles until they had been slated for an issue. So in any case, I won't drag you all too far down that rabbit hole, but I think it's good for me to let you know, and as I said, for other listeners to know, those things have changed. And I'm really pleased, at least if there was a delay, that you felt like there was some level of communication and certainly kindness about what was happening. But, you know, especially with studies like yours, these are things that we want to get as quickly as possible into the hands of your DO colleagues and readers, so that they have that data to change patient care, the way that they're approaching their patients, the way they're educating their patients. And that's really the function of the JAOA. So we have made some efforts to achieve that function a bit more smoothly and better than we have in the past. So was there anything that you learned during this research project that you'll take into the next one or do differently? Obviously, Dr. Berry, you're already undertaking some research on the educational program. So what did you take with you? What would you do differently the next time?
I think so. Amanda, are you using morphine equivalents in your project, or are you not looking at all at what you're prescribing, just disposal?
No, this was just purely on disposal. We talk about number and then routes of delivery, like number of pills and routes of delivery, but not how many morphine equivalents they're getting. I think that would be a great done as well, but that's not part of this paper.
Okay. Yeah, part of our IRB process, and I was brand new to the process and study design, obviously, as a third-year resident when I was developing this project, was our IRB coordinator had recommended that we come up with a way to standardize the prescriptions given to patients. And so we decided as one of our inclusion criteria that it would be our standard prescription that we give patients. The problem with that is it excluded a lot of possible patients who had allergies to certain things or reasons they couldn't take certain medications. And so it would have been much better to standardize it by morphine equivalents. That would have been the easiest way to do that, and not something I really thought about until later on. So that was one thing I learned. The other thing, just being somewhere else now and having a different research infrastructure, is we have amazing software for survey-based projects where patients get emails, they get reminders, they're really, really easy to get a hold of. Patients seem to be much more likely to answer emails and fill out surveys that way than actually talk on the phone or pick up their phone in general.
Right.
And so I feel like if you have the availability to use software-based surveys, that would be one of the ways to do this.
That makes a lot of sense, and I think those are good tips for other researchers.
Mm-hmm.
So thank you both for joining me today. I think this was really some great insight into the article and went beyond the interview that you recently did in the DO, and I'm so happy to be featuring you both and your research on this episode. So thanks so much for joining me today, and thanks for publishing with the JAOA.
Thank you for having us.